In this channel we offers you a deep dive into the world of medicine and healthcare, where insightful perspectives, medical updates, and expert insights are shares. Join the journey to gain a better understanding of various health topics and stay informed with the latest medical breakthroughs. Today we will discuss about how to approach a patient with acute abdominal pain. We will start with a case history followed by presentation on the topic. A 35-year-old female presented to the emergency department with acute abdominal pain localized to the right lower quadrant. The pain was sudden in onset and accompanied by nausea. On physical examination, there was tenderness in the right iliac fossa with guarding and rebound tenderness, raising concerns for possible appendicitis. Initial paraclinical investigations included a complete blood count revealing an elevated white blood cell count of 14,000/mm superscript 3, indicative of an inflammatory process. The C-reactive protein level was also elevated at 30 mg per liter, further supporting the suspicion of an acute inflammatory condition. A urinalysis was performed to rule out urinary tract involvement, and the results were within normal limits. Given the clinical presentation and laboratory findings, a focused ultrasound of the abdomen was conducted, revealing an inflamed and enlarged appendix with signs of appendicitis. The patient was promptly scheduled for an emergency appendectomy. Postoperatively, the patient's recovery was uneventful, and follow-up blood tests demonstrated a normalization of the white blood cells and C-reactive protein levels. Histopathological examination of the removed appendix confirmed acute appendicitis, supporting the clinical diagnosis. The patient was discharged with appropriate postoperative instructions and a plan for further outpatient follow-up. In this case, the comprehensive approach to the patient's abdominal pain involved a combination of clinical assessment, laboratory investigations, and imaging studies. The complete blood count and C-reactive protein provided valuable information about the inflammatory response, guiding the decision for surgical intervention. The urinalysis helped rule out alternative causes of abdominal pain. The use of ultrasound played a crucial role in confirming the diagnosis of appendicitis, guiding timely surgical management. The patient's smooth recovery and normalization of postoperative laboratory parameters underscored the accuracy of the diagnostic and treatment strategies employed. In conclusion, the integration of clinical, laboratory, and imaging findings allowed for a comprehensive evaluation of the patient presenting with abdominal pain. The timely diagnosis of appendicitis and subsequent surgical intervention were pivotal in ensuring a favorable outcome for the patient. This case exemplifies the importance of a systematic and multidisciplinary approach to abdominal pain, emphasizing the significance of paraclinical investigations in reaching an accurate diagnosis and implementing appropriate interventions. In second part we will have a comprehensive approach of a patient with acute abdominal pain. Introduction. Acute abdominal pain is a common presentation in medical practice, encompassing a wide spectrum of potential causes, ranging from benign to life-threatening. The assessment and management of a patient with acute abdominal pain require a systematic and thorough approach to ensure timely diagnosis and appropriate intervention. In this comprehensive guide, we will explore the key steps in approaching a patient with acute abdominal pain, emphasizing the importance of history taking, physical examination, and relevant investigations. History taking. 1. Onset and duration. Begin by eliciting information on when the pain started and its duration. Acute abdominal pain may have sudden or gradual onset, providing valuable clues to the underlying etiology. 2. Characterization of pain. Understand the nature of the pain by asking the patient to describe it: sharp, stabbing, crampy, etc. This helps in differentiating between visceral and somatic pain and narrowing down possible causes. 3. Localization. Pinpoint the exact location of the pain. Different abdominal quadrants may correspond to specific organs, aiding in the differential diagnosis. 4. Aggravating and alleviating factors. Identify factors that worsen or alleviate the pain. This information assists in determining the cause and potential complications. 5. Associated symptoms. Inquire about accompanying symptoms such as nausea, vomiting, fever, changes in bowel habits, or urinary symptoms. This provides additional clues for diagnosis. Physical examination. 1. Vital signs. Begin with assessing the patient's vital signs, including heart rate, blood pressure, respiratory rate, and temperature. Abnormalities may indicate systemic involvement or severe pathology. 2. Abdominal examination. Perform a systematic abdominal examination, including inspection, palpation, percussion, and auscultation. Note any tenderness, guarding, rigidity, or organomegaly. 3. Digital rectal examination. Consider a digital rectal examination to assess for rectal tenderness, blood, or masses. This is particularly important in cases of lower abdominal pain or suspicion of colorectal pathology. 4. Pelvic examination. In female patients, a pelvic examination is crucial to identify gynecological causes of abdominal pain. Evaluate for signs of pelvic inflammatory disease, ectopic pregnancy, or ovarian pathology. Investigations. 1. Laboratory tests. Order routine blood tests, including a complete blood count, comprehensive metabolic panel, and coagulation studies. Elevated white blood cell count or abnormal liver function tests may provide diagnostic clues. 2. Imaging studies. Based on the clinical presentation, employ imaging modalities such as ultrasound, computed tomography, or magnetic resonance imaging to visualize abdominal structures. These aid in identifying structural abnormalities or pathology. 3. Specialized tests. Consider specialized tests like amylase and lipase for suspected pancreatitis, or urine analysis for renal or urological issues. Tailor investigations to the suspected underlying cause. Diagnosis and differential diagnosis. 1. Synthesize information. Integrate the data gathered from history, physical examination, and investigations to formulate a working diagnosis. Consider the most likely and potentially serious causes. 2. Differential diagnosis. Maintain a broad differential diagnosis to avoid tunnel vision. Common causes include appendicitis, cholecystitis, diverticulitis, or peptic ulcer disease, but rarer conditions should also be considered. Management. 1. Pain control. Alleviate pain using appropriate analgesics while considering the underlying cause. Be cautious with opioids to prevent masking symptoms that aid in diagnosis. 2. Fluid resuscitation. Administer fluids to address dehydration or hypovolemia, especially in cases of severe pain, vomiting, or suspected intra-abdominal bleeding. 3. Surgical consultation. Promptly involve surgical consultation for conditions requiring urgent intervention, such as appendicitis, bowel obstruction, or perforated viscus. 4. Medical management. Initiate medical management based on the identified cause. Antibiotics, antiemetics, or other specific therapies may be warranted. Conclusion. Approaching a patient with acute abdominal pain demands a systematic and comprehensive strategy, integrating thorough history-taking, meticulous physical examination, and judicious use of investigations. A holistic approach ensures timely diagnosis and appropriate management, improving patient outcomes and minimizing complications. Healthcare professionals must remain vigilant, considering both common and rare etiologies, to provide optimal care for individuals presenting with this challenging and diverse clinical entity.